Hello, everyone. My name is Haley Ditterman, and I'm the Executive Director of the Triple Negative Breast Cancer Foundation. Thank you so much for joining us today for the medical update on triple negative breast cancer. Today we have with us Dr. Rita Nanda. She is an Associate Professor of Medicine and the Director of the Breast Oncology Program at UChicago Medicine. While she specializes in the treatment of all forms of breast cancer, her practice focuses on women with triple negative, hereditary, locally advanced, and metastatic breast cancer. I'm proud to say that Dr. Nanda is a member of the Triple Negative Breast Cancer Foundation Board of Trustees and thrilled to have her with us here today. Dr. Nanda is going to be starting her presentation, and I will be back in a bit for the Q&A. Dr. Nanda?
Thank you so much, Haley, for that kind introduction. And I'd like to thank the Triple Negative Breast Cancer Foundation and Living Beyond Breast Cancer for inviting me to be part of this symposium. I'd like to present over the next few minutes a very high-level summary of updates in what's going on in the triple negative breast cancer field. So just by way of some background, I think many of you know triple negative breast cancer is a form of breast cancer that lacks expression of the estrogen, the progesterone, and the HER2 receptor. So whenever we diagnose anyone with breast cancer, we always do these 3 special stains on the tumor to help figure out what type of breast cancer someone has, because we know there are different types of breast cancers, and the type of breast cancer helps us decide how we're going to treat any given cancer. Triple negative breast cancer accounts for about 15 to 20% of all breast cancers that are diagnosed in the United States. And it has a tendency to be more common in younger women who are premenopausal, in women of African and Hispanic heritage, as well as in those who have BRCA1 germline mutations. And historically, up until the past few years, the treatment options have been really limited to chemotherapy. Now, I get asked many times about what type of triple negative breast cancer do I have? And we know from work that's been done out of Vanderbilt University in Dr. Pietenpaul's lab that there are at least 4 distinct subtypes of triple negative breast cancer. And this is based on expression profiling that was done on a set of more than 700 triple negative breast cancers. There's the basal-like subtype 1 and 2, the luminal subtype that a lot of times has overexpression of the androgen receptor, and then the mesenchymal subtype. And this is not testing that we generally do in the clinical care setting. This has primarily been investigated to date as a research tool. So it's not something that I generally do in my clinical practice outside of a clinical trial. So I think I just wanted to make sure that you all know that, we don't do this testing because in 2020, we don't know what to do with these results. And every patient with triple negative breast cancer is potentially eligible for all of the therapies that are being developed for triple negative breast cancer. So when we look at the NCCN guidelines and what treatments are available for those individuals who have triple negative breast cancer, you can see that most of the therapies are chemotherapies. And we have a number of different chemotherapies that can be very effective against triple negative breast cancer. Most recently, we've also seen approval of the PARP inhibitors for those individuals who have BRCA1 and 2 germline mutations, as well as immunotherapy for those triple negative breast cancer patients who have tumors that express the PD-L1 protein. And I'm going to get into that a little bit later. So the PARP inhibitors were the first targeted therapies that were approved for metastatic triple negative breast cancer. And the approval is really limited to those patients who have germline mutations in BRCA1 and 2. The Olympiad trial and the Embraca trial, which led to the approval of olaparib and talazoparib, showed that PARP inhibitors, when they're given by themselves, are actually more effective than standard of care chemotherapy for individuals who have these mutations. So this was really a great breakthrough for that subset of individuals with BRCA1 and 2 germline mutations. and triple negative breast cancer. There's a third PARP inhibitor called veliparib that has been investigated, given in conjunction with chemotherapy with some promising results. And this is not currently FDA approved, and we'll see what the FDA thinks about the combination of a PARP inhibitor plus chemotherapy, and if that might be another approach to take for individuals with BRCA1 and 2 advanced triple negative breast cancers. Next came immunotherapy, and this was the Impassion 130 trial that led to the approval of atezolizumab to be given in conjunction with the chemotherapy nab-paclitaxel for those individuals with PD-L1 positive triple negative breast cancer. In this trial, about 40% of the individuals who participated had PD-L1 positive triple negative breast cancer. And what you can see here from the curves where we look at how long the cancer remains under control, something called progression-free survival, and how long individuals live, overall survival, you can see that those who got the immunotherapy drug atezolizumab had their cancer remain under control longer and lived longer if they received atezolizumab with chemotherapy. So a really exciting advance for women and men with PD-L1 positive triple negative breast cancer. The Keynote 355 trial investigated the immunotherapy drug pembrolizumab, and it was given with chemotherapy here. This trial was a little bit different. It allowed physicians' choice of chemotherapy, so it included nab-paclitaxel, paclitaxel, or carboplatin plus gemcitabine. And again, very similar to what we saw with the Impassion 130 trial and atezolizumab, when pembrolizumab was added to chemotherapy, it helped the cancer remain under control for longer. This regimen is not yet FDA approved, although I do know the FDA is reviewing this, and we could very well see in the not too distant future an approval for pembrolizumab as well, which would be really exciting. Moving on to talk a little bit about a drug called sacituzumab govitecan. This is a new class of chemotherapy drugs called an antibody drug conjugate. And this treatment consists of what I like to call targeted chemotherapy. So there's an antibody that binds to this protein called TROP2, which is overexpressed in a lot of different types of breast cancers, in particular triple negative breast cancer. And so this antibody binds to this protein on triple negative breast cancer cells and allows for this whole antibody plus the chemotherapy drug to be internalized, so swallowed up by the cancer cells. And when that happens, the chemotherapy is released into the cancer cells and kills that cancer cell sort of from the inside out. And most recently, we just saw last week, actually, a phase 3 trial of sacituzumab versus chemotherapy of physician's choice. And what we saw was that those individuals with advanced triple negative breast cancer who received sacituzumab lived longer than those patients who received standard of care chemotherapy, twice as long. So really impressive results. There are other what we call antibody drug conjugates in development for advanced triple negative breast cancer. Ladiratuzumab, which targets a protein called LIV1A, and trastuzumab deruxtecan, which targets the HER2 protein and is already FDA approved for advanced HER2 positive breast cancer, but is also being expressed for triple negative breast cancers that have a lower level of HER2 expression, but not that high level that would make them HER2 positive. Sacituzumab, these results have been so impressive. This drug is FDA approved. It was FDA approved for advanced triple negative breast cancer earlier this year. And there are many trials ongoing looking to combine it with immunotherapy, as well as moving it up into the early stage triple negative breast cancer setting to be given with sort of chemotherapy in that neoadjuvant, so prior to surgery setting, or after surgery for individuals who don't have a complete response to the chemotherapy that they've received. So it's been really exciting over the last few years to see the approvals that have led to dramatic changes in how we treat metastatic triple-negative breast cancer. In 2018, we saw the approval of olaparib and talazoparib, the PARP inhibitors for individuals with metastatic triple-negative breast cancer in the setting of a germline mutation in BRCA1 or 2. In 2019, we saw the approval of the immunotherapy drug atezolizumab to be given with nab-paclitaxel for those individuals with PD-L1 positive triple-negative breast cancer. And then earlier this year, we saw the approval of sacituzumab govitecan for all triple-negative breast cancer patients with metastatic disease. So really exciting advances in the past few years. I wanted to just comment on some of the research that's ongoing or will soon be coming down the line. I think that there's been a lot of interest in looking at using some of the drugs that are FDA approved for prostate cancer that target the androgen receptor for metastatic triple-negative breast cancer that expresses androgen receptor protein. This is probably about 10 to 15% of patients with triple-negative breast cancer. There have been a number of studies that have looked at these drugs, these anti-androgen receptor drugs alone with some modest effectiveness, but they've never been compared head-to-head to chemotherapy. So Dr. Traina and I will be co-leading a trial where individuals with metastatic triple-negative breast cancer that is androgen receptor positive could participate in these trials, these patients, and would be randomized to chemotherapy or enzalutamide-based therapy, either alone or with a drug called mifepristone that we think targets a mechanism of resistance to enzalutamide therapy. So this trial will be conducted through the TBCRC and will be opening in the not too distant future. So I just wanted to summarize to talk a little bit about the drugs that are in development now, are FDA approved, immunotherapy, PARP inhibitors, and the antibody drug conjugate sacituzumab are FDA approved for individuals with metastatic triple-negative breast cancer. And trials are ongoing, actually moving all of these therapies up into that early stage setting to see if we use these drugs instead of standard chemotherapy or in addition to standard chemotherapy, can we cure more women with early stage breast cancer? And then ongoing trials looking at the androgen receptor and antagonizing it for metastatic breast cancer. I think it would hold a lot of promise for those subset of patients with androgen receptor positive triple negative breast cancer. So that was a pretty quick overview, but I just wanted to review what's been going on in this space and where we hope to go in the next few years for triple negative breast cancer. Thank you.
Hello, Dr. Nanda. Thank you so much for that wonderful presentation. It was really a great summary of where we are and hopefully where we're headed. I know that so many of the women that I speak to and caregivers have so many questions, and I thought, it might be nice for you to be able to address some of them. So first of all, what makes triple-negative breast cancer more difficult to treat than other forms of breast cancer? We get that question a lot.
Yeah. And, I think a lot of that is related to some of what I just covered. Historically, it's just been chemotherapy. It hasn't been targeted therapies that we've had available to treat triple negative breast cancer. And chemotherapy, can be very effective in treating triple negative breast cancer, particularly in that early stage setting where a large majority of women are actually cured of their early stage disease. But in the advanced cancer setting, when we're going from one chemotherapy to another, there are side effects related to chemotherapy, and chemotherapy generally only works for a short period of time, any given drug, before we have to move on to something else. I think some of these drugs that have been FDA approved in the last couple of years, and just look at how much we've accomplished in the last couple of years. For triple negative breast cancer. The PARP inhibitors, immunotherapy, now sacituzumab, these drugs have all been shown to work longer for women with metastatic triple negative breast cancer. And so I think that targeted therapies a lot of times can come with fewer, although sometimes different, side effects than chemotherapy has, but the potential that they can work for longer, I think, is the really exciting part of where we've come in the last couple of years. And there's a lot more that we want to do and accomplish. And as researchers, we're not going to rest until we've identified great therapies for every woman and man with triple negative breast cancer.
Well, that's music to our ears, obviously. And you're talking a lot about clinical trials and research that you're excited about. How important is it that clinical trials be inclusive of a wide range of patients? Just because there's a lack of representation of minority populations in many clinical trials. And I know that that's very significant. I was wondering if you could explain why and how it would benefit to have a diverse group represented.
I think that's a really important point that you've made, Haley. It is important to have diversity in enrollment to trials. Different racial and ethnic groups can sometimes have different responses to therapies or different toxicities. And we've certainly seen that in drugs like capecitabine, where we use it very frequently for individuals with triple negative breast cancer, either in the sort of post surgery setting for women with early stage breast cancer, and in the metastatic setting for patients with metastatic triple negative breast cancer. And different ethnic groups do have different tolerabilities and toxicities, and the taxanes are another, certain populations are more at risk for neuropathy than others. So it is really important for us as we're developing these therapies and strategies that we have a diversity of individuals in terms of racial and ethnic groups who participate in trials. And it's also really important for everyone to have access. And I think we, as a research community, need to work on that and proactively get out there and ensure that we've got a diversity in enrollment to trials.
Okay, thank you. And, as someone who works so closely with patients, I'm sure you've noticed that with our triple negative community, the fear of recurrence is really great. What would you say to someone who is a couple of years post-treatment, who is living with that fear of recurrence daily? It's part of their life. How would you address that? And what can they do?
No, I think that's a really great point. And I definitely go through that with patients as they're, completing their therapy, and then they're in follow-up mode after a diagnosis of early stage triple negative breast cancer. I think there are many trials that are ongoing to see if we can further reduce the risk after individuals with triple negative breast cancer have completed their early stage therapy. There are vaccine trials, there are immunotherapy trials, there's more chemotherapy after surgery, particularly for those individuals who haven't had a complete response to the therapy that they received prior to surgery. But, I think everyone should feel empowered to live a healthy lifestyle, because we know that having a healthy body weight, exercising, getting your heart rate up 30 minutes at a time, 5 days a week, limiting alcohol consumption, eating a heart healthy diet, low fat, high fiber, plenty of vegetables and lean sources of protein in the diet are all things we know can further reduce the risk of a recurrence. And so I would empower all of my patients and others out there who are living with a diagnosis of triple negative breast cancer to incorporate this and feel that they have control over the risk of recurrence. So a lot of times that is how I approach it with my patients in my clinic. And if we ever find that anxiety or concern is so overwhelming, we have a psych oncology program. There are many support groups and therapists and psychiatrists who can help individuals who feel like that risk is overtaking that risk of recurrence, fear is overtaking their life, so that they can move on and not worry about it as much.
Thank you for that. And I think this is a good place to also mention that the Triple Negative Breast Cancer Foundation and Living Beyond Breast Cancer, we have so many resources to address that need because it's very real for all breast cancer patients, but I think especially in the triple negative community. My next question, and it's one that we hear a lot from patients who want to know what progress is being made in understanding the biology behind triple negative breast cancer. So for example, biomarkers, that always seems to come up.
Yeah, no, I think that's a great question. And, what I would say is biomarkers have really been what's led to the approval of a number of the targeted therapies in the past few years. So we know that for PARP inhibitors, having a BRCA1 or 2 germline mutation is what's needed to allow for a response to that therapy. We also know that PD-L1 positivity, while it's not a perfect biomarker, correlates with response to immunotherapy, although there is a lot of work ongoing in that space with immunotherapy to see if we can identify better biomarkers of response, as well as strategies that can help the immunotherapy work even in individuals who don't have PD-L1 positive breast cancer. So many, many trials looking at that. Sacituzumab, interestingly, works, it's a targeted chemotherapy, but it works in all-comer triple-negative breast cancers, although there will be, I believe, some data coming out at San Antonio as to whether or not there's a biomarker there. That targeted chemotherapy targets a protein called TROP2. And so there's a lot of interest in looking at that protein and if that helps us identify who's most likely to benefit. The work that I'd mentioned early on in my talk about the 4 different subtypes of triple negative breast cancer, at least when we look at the expression of thousands of genes and proteins in a given tumor, is really used as a research tool to try to identify new targets that might be helpful to treat the different sort of forms of triple negative breast cancer, because we know that triple negative breast cancer isn't one disease. I think an area that Dr. Trina and I have been interested in is androgen receptor positive triple negative breast cancer and how effective repurposing some of those therapies we use to treat prostate cancer could be effective. Enzalutamide or enzalutamide plus a drug called mifepristone that targets mechanisms of resistance to enzalutamide. So I think there's a lot of work ongoing, but you are absolutely right. It is identifying different subgroups of triple negative breast cancer and then trying to tease out what's driving them and then target what's driving those different subtypes. And so that is really where we're headed in the future, and I think will be responsible for many more success stories down the road.
That's really good to hear. We hope so. And this is a very timely question. So now that we're in this global pandemic, so many women who are just recently diagnosed have an added burden of navigating this disease while also adhering to certain guidelines, depending on where they live and so on. What would you suggest for patients who are looking to advocate for themselves, and even for the caregivers listening today? What would you suggest that they do to make sure that they're getting the treatment that they need, given the added burdens that we're experiencing with COVID?
I have to say, fortunately, I believe in most places across the United States, treatment is proceeding. Screening, treatment, follow-up appointments are really back to sort of normal pre-COVID settings at this point. The one thing that I would say is really positive that's come out of this whole pandemic is the ability to get a second opinion virtually. And I would encourage individuals to consider that as an option. I am seeing many more patients from all over the country now with triple negative breast cancer virtually, just for a second opinion. And I think that it's for women who are in rural areas or have, transportation issues, who can't maybe necessarily travel a few hours for a second opinion. I think a virtual second opinion, and many insurance companies do cover them, is a great way to ensure that your data is being reviewed by individuals maybe at an academic center to ensure that you're getting the treatment that you want and need. I think the other thing I would say is, given the sort of widespread use of Zoom and other platforms to do interaction with other individuals who are facing the same challenges, I think can also be really helpful. There's now access to a virtual community online that individuals can tap into. And I think that is really helpful, because I think it's really important to remain connected even when we need to be socially distancing and wearing masks. But I think there are some positives that have come out of the pandemic. And I think these things will remain even after life gets back to a more normal way.
Thank you. And I really have noticed that in my work with the Triple Negative Breast Cancer Foundation as well. We've started doing monthly community Zoom meetings, and we get dozens, up to 200 people registered sometimes for a single meeting. And like you said, there's nothing really like learning from each other. So it's nice that is an opportunity now for people. But the second opinion scenario, that's something I didn't consider, that is now available to patients everywhere to really have their case reviewed by people in an academic center. So that is great advice. And then finally, I wanted to ask, kind of to sum up, where do you see treatment options for triple negative breast cancer in 5, 10, or even 20 years from now?
Yeah, that's a great question. And I think, when I think about how we develop drugs for any kind of cancer, we always study drugs in the advanced cancer setting. And as we see promise there, we move those drugs up to the early stage setting. And that has historically been how we've pushed the field forward. So the trials that we're doing now for advanced stage disease, or the drugs that are now recently approved in the past few years for advanced stage disease, are all being investigated for women with early stage triple negative breast cancer. And I think that's where we can look to see where the field is heading. Immunotherapy has already shown remarkable promise for individuals with early stage triple negative breast cancer, is currently being reviewed by the FDA, and very well could be approved this year for early stage triple negative breast cancer. Immunotherapy is also being investigated in individuals who've not had a complete response to their chemotherapy in the adjuvant setting. So after they've completed their initial chemo and surgery and radiation if they've needed it. So I think we'll continue to see improvements in the use of immunotherapy for women with early stage breast cancer, potentially incorporated into chemotherapy regimens in that setting. For advanced triple negative breast cancer, new combination strategies, more biomarker work trying to identify who are those individuals who are most likely to benefit, and how can we take those who aren't benefiting and make them benefit by either novel combination strategies. We've also got sacituzumab now, which has really been a very impressive drug for individuals with metastatic triple negative breast cancer. And that drug is being moved up into the early stage setting as well. PARP inhibitors as well are being compared to chemotherapy in the early stage setting. And then for individuals with advanced triple negative breast cancer, I've already talked a little bit about the androgen receptor and how it can be positive in about 15 to 20% of metastatic triple negative breast cancers. And we're looking at targeted therapies versus chemotherapy in that setting, combination strategies to try to overcome resistance to androgen receptor blocking agents. And there have already been trials and ongoing trials moving that drug up to the early stage triple negative setting. And then there are other targeted chemotherapies, so these antibody drug conjugates that are being investigated for individuals with advanced triple negative breast cancer. So I think we're going to see more and more as we move forward, biomarkers that help predict for a benefit from a variety of different therapies. We're going to be seeing new targeted chemotherapies, so these antibody drug conjugates, and new strategies looking at immunotherapy and how we might be able to have more individuals with triple negative breast cancer benefit from that.
It's so exciting, especially knowing where we came from. So many, even a decade ago, the medical landscape and the treatment options were so much more limited, and there's so many exciting things coming down the pike. And it's very encouraging that there are so many more options today than there were before. I want to thank you so much for your time. We enjoyed the presentation and all the information you were able to provide during the Q&A. And looking forward to continuing to work with you. Thank you for everything and for your work with the triple negative community.
Thank you so much for having me. It's a real pleasure to be here.